Thanks, Brett. I'm reaching for my wallet to give you
$20.
20. Is it $20 now? Well, it's gone up. Um, can you hear me, everybody? Okay. All right. So I'm getting the thumbs up. So who do I tell to move forward the...
You have your mouse up there.
I have my mouse up here. Okay.
And just roll it. There you go.
All right. So we're rolling. All right. So what we're going to talk about tonight is, I'll put it in perspective with, if you remember back just a few short years, the actress Farrah Fawcett, who now has a group that supports anal dysplasia, anal cancer. So Farrah Fawcett actually died of HPV anal cancer, had no idea that it is even an issue. So what we're going to talk about tonight is there are things now that can be done about this to help prevent these. One of which is, I've put on the screen here, giving someone the finger doesn't have to be a bad thing, right? So having an exam in the anal area is always a good thing whenever you're being screened. So let's move forward. So we're going to talk about anal dysplasia, to treat or not to treat. That's the question. My name is Jon Colbert. I'm a family nurse practitioner, an HIV expert, and I currently practice out of the Eisenhower Mike and Jan Salta Health Center on the main campus of Eisenhower, as well as the Rimrock Health Center. So what is anal dysplasia? Basically, anal dysplasia is defined as anal interepithelial neoplasia. Dysplasia is the presence of abnormal cells within a tissue. So neoplasia is new growth of cells, typically like tumor cells. It can be benign or they can be malignant. And dysplasia often refers to an early stage of this process. So we're going to be a little technical here in the beginning, and then we're going to break this down to just basic information. So there's a two-tiered system as we work with those that have HPV. So let me go back just a little bit. And HPV is a really common virus. Human papilloma virus is what it stands for. And that virus is a skin-to-skin contact. That's how you get transmission. So oftentimes people say, well, how do I not get it? Well, you don't get it by never having any sort of contact with another human being. So, I mean, that's kind of tough, you know. So if anyone has ever had sex and you've had sex in such a way that it's condomless, which most everyone has had at some point in their life, you probably have picked up this virus. There's about 100 different types of it, of which now we can immunize kids who've never had sex against the 9 cancer-causing ones, because most of these viruses just cause warts, are not problematic whatsoever. However, there's a couple of viruses, types 16 and 18 of the 100, which cause about 90% of the cancers. Farrah Fawcett actually succumbed to HPV type 16 and eventually cancer. So there's a two-tiered system. When you have HPV and you do this procedure that we're talking about, which Brett referred to, which is called high resolution endoscopy, which is one of the choices that you have to be proactive once you have this virus. So as an individual, if you get that diagnosis, you can do absolutely nothing, and chances are good that nothing may happen. Or you could go in and do an exam with your primary care physician or provider with a finger, because if something's growing there, they can feel it. Or you can come in and be proactive and find an HRA provider, high resolution endoscopy provider, who actually can go in, similar to what women have dealt with for years with pap smears. It's a very similar process, only it's in the anal canal. Men and women get this. In fact, I have many women in my practice who are more mature and who have in fact had cancer, and now are watching to make sure it doesn't come back. and they're always confused about why this happened. So it's a two-tiered system once you get into it. And basically, you can't see this very well, but it shows a low-grade squamous epithelial lesion on the left. And these typically present themselves as what's called AIN1 or condylomas. And you get the sense from this picture how there's variation in the cells and there's changes that begin to happen. As this progresses over time, you turn into what's called high-grade squamous interepithelial lesions. Those are grade 2 and grade 3. You see at the top, there's CINs and AINs. Those are cervical, and anal is what that's representative of. If you look towards the right, you'll see that those cells have continued to multiply. They get closer, and there's nowhere to go except down. And when it goes down like that, it's going into your body. That's what that's representative of, which is what happened to poor Farah. So cancer actually spread throughout her body. Now, this process takes quite a while to develop. It's not something that happens in a short amount of time. Okay, so low grade versus high grade. Dysplasia can be either low grade or LGSIL or LSIL, which is a low grade squamous lesion. It typically does not progress to cancer, and that's the most often sort of a lesion that we'll find. It is synonymous with what you'll see as AIN1. It's synonymous with warts. Warts are common as well. It's usually associated with low risk HPV. A high-grade lesion is a high-grade squamous interepithelial lesion. It, in fact, can progress to cancer. It's associated with AIN2s and AIN3s. Those are precancerous type lesions. And here in my practice, I probably find 3 to 4 of those a week, and I see probably 30 patients a week. So that kind of gives you the idea of how common it is. It's usually associated with high risk HPV, including 16, 18, and 45. Most cases of anal cancer, as I mentioned earlier, are caused by 16 and 18. So if you're an individual who has type 16 or 18 HPV, we're going to see you more often than the individual who has the lower risk types, if that makes sense, because you're at a higher risk factor. All right. So the anatomy of the anus, we're not going to go too far inside. People think that we're way up inside. They say, well, how come, is this like a colonoscopy? It's really not. We're only about 4 to 5 inches up in the anal canal. And if you notice that area here called anoderm, if you look at the bottom, you'll see anoderm. That's tissue that's very similar to the tissue that we have all throughout our bodies on the outside. And that can be affected by HPV very simply. So prepare your anus because we're on our way. I thought I would have a little lightheartedness to this, just a little bit. I don't see anyone laughing here, so we'll move on. So some risk factors. HIV infection. It definitely increases the prevalence of HPV infection, especially in the higher risk strains. So an HIV infected individual who has the high risk HPV virus in the anal canal is about 40% higher than the general population of developing anal cancer than the general population. People that have lower CD4 counts, in other words, that people that have immune system suppression from organ transplant to people that are on different medications, CD4 counts low are also a factor for developing HSIL. So again, immunosuppressed patients due to solid organ transplant, women that have a history of HSIL on the genital tract when they do pap smears and colposcopy, anyone who's had a history of genital warts, that's mean you've come in contact with HPV, you need to take a look at, do you only have the low risk types of HPV, or do you concomitantly also have high risk HPV? Men who have sex with men tend to have a higher rate of HPV than does the heterosexual population. In the Accord study, this talks about the rates of cancer in HIV infected men. So 46 per 100,000. In 377 HIV positive men who have sex with men, I think somebody's trying to get in to the meeting, with HSIL that progress every year to anal cancer since the introduction of the medications that we're using. People that have HIV are living longer, therefore they have more time for progression to cancer. So the widespread use of these medications for HIV has had a profound impact on reducing HIV/AIDS associated malignancies and such, but it does not appear to have had any sort of a positive impact on anal cancer. In fact, that has actually gone up, as have other issues that are associated with aging. Women with HIV have an increased risk of abnormal cytology and also having high-grade anal intraepithelial lesions. And they do not have to have anal receptive intercourse. So the use of toys, the use of fingers, oral sex can all introduce HPV into that anal canal. So HPV, as I mentioned, there's about 150 different types. Those are some of the ones that are listed here. It's a papilloma virus because they're known to cause warts. Some can cause cancers, including cervical cancer, vulval cancer, anal cancer, mouth, penis, and throat. In fact, Marcia, I forget her name, one of the actresses that were on the Desperate Housewives series, Marcia Cross, she developed anal cancer. She wrote an article not too long ago, you can look it up online, and she was not happy that, you know, this information was not readily available. At the same time, her husband developed throat cancer. As they looked at these viruses, they found that the virus was the exact same one. In fact, that's probably how one of the two of them gave it to the other. So spread through direct skin-to-skin contact and through bodily fluids. And it's very common to have it. If you've had sex, you probably have it in some form or fashion. It doesn't mean you're going to have the high risk types, but you need to find out. This talks a little bit about the vaccine. So today there are vaccines, and when this vaccine was studied, it was studied on women only. And so insurances could only approve it or would only approve it for women originally. You know, and the joke for all of us was, well, where are they getting this virus? They're getting it for men. Why aren't we using this on men as well, or boys? So it's now approved for both girls and boys. And they bumped the age from, I think it was 26 originally, it's now up to 46. So anyone who's up to age 46 can in fact get this vaccination. If you already have the virus, the questionable thing about this is that, you know, does it make sense to get it? It can't hurt you, but does it really help? Because the point of this vaccine is to keep you from getting the virus. If you already have the virus, you know, we don't know if it's really going to help or not. Anyone who can, after the age of 46, can in fact get this immunization, but they would have to pay for it because insurance will only pay for it up to age 46. And that's because they assume you've already had sex. So prevention, there's primary prevention, which is basically getting an immunization. There's secondary prevention, which is screening for these things, which is what we're talking about. There's pap smear testing and HPV testing, which is what we often do, male pap smears in the anal canal. People think that paps are just for women. They're not. Pap smears can be done on women's anal canal, men's anal canal. You can get the immunization Gardasil. It speaks to what we just talked about here. And then what's interesting is the uptake in the United States of this vaccine is pretty poor, despite the proven reduction of cervical cancer rates. And in my own opinion, this has to do with, mom and dad don't want to, the kids would be getting this at age 10 and 11. They don't want to think of Susie or Johnny having sex. And I've had many cases in my past where, parents just refuse to do this because it's almost like, giving them the approval to have sexual activity. I've also done some work in European communities, and in fact, the uptake of vaccine in Europe, in the European countries, is much higher than it is in the U.S. So if you know anybody who has kids that aren't sexually active, get them in, recommend that they go in and get this Gardasil. It will keep them from developing these HPV issues when they're more mature. Okay, some guidelines for screening. There's actually no national screening guidelines for anal cancer. There are studies that are going on right now to try to prove the effectiveness of what we're doing. Those of us who do these procedures feel like we're pretty certain that this will all be approved eventually, but we have to prove it in numbers in the US these days, and that's how medicine works. So there's studies that are ongoing right now. The CDC acknowledges that some experts recommend anal cytological screening for HIV positive men and women. In the state of New York and the Public Health AIDS Institution, clinicians should obtain anal cytology. Those are recommendations, and annually for HIV infected populations. Anyone who's MSN, any men who have sex with men, any patient with a history of anogenital condyloma, which is just a fancy word for warts. Women with abnormal cervical or vulvar cytology. And then the American Society of Colorectal Surgeons also speaks into it. They give it a strong recommendation to begin screening and follow-up. So the medical community is behind this. It's just we have to prove that it's effective before there'll be guidelines that are across the US. Okay, so don't get behind here. Is everybody with me? Do we have any questions at this point? All right. So who should be screened? So HIV positive men and women over the age of 30. There's a low incidence of anal cancer younger than 25. So if I have someone sent in to me that young, then we'll go ahead and see that individual, but typically then they're fine and we'll see them a few years later. Men who have sex with men, HIV negative over the age of 40. Immunosuppressed patients, we see a lot of immunosuppressed patients. Women that have had a high history of high-grade cervical, vulvar, or vaginal dysplasia cancer. I mentioned earlier, I have right now, it's probably about 12 women that are in their 60s and 70s who say, we have no idea how this happened. They're really confused about it all, but they in fact have gotten over anal cancer, and they're now coming in to just ensure that they don't develop another lesion. And then any individual who has a history of anal warts should be screened. So we do the screening with a pap smear. It really is operator dependent in terms of how well or how good the results are going to be. Oftentimes when I screen patients who've been screened before, they will say to me, I've never had that sort of a test done before, even though they thought they did, and they often did have. So if someone's not trained on how to do these anal pap smears, then find someone who is trained to do these, because if not done properly, you can get a false negative. So you think nothing's there. In fact, it is. Ascus, atypical squamous cells of undetermined significance is cytology. Happens all the time. We see people with ascus cytology, L-seals, but primarily we see H-seals and ascus. That's a lot of information. Just know that if we find anything that's atypical, we need to look further. If we develop what's called an H-seal when we do the screening PAP, chances are really good. And in my practice, I find that someone will always have a high-grade lesion that needs treated. So these things are pretty effective. So in anal cancer, early detection is the key. I'll just tell you a little short story. My ex-partner many years ago was being treated for hemorrhoids. This is a common complaint. You get treated for hemorrhoids with your primary care doctor, you don't really get any better. And in fact, for 6 months, he wasn't getting any better. I finally stepped in and pushed it, and we got him into colorectal people who in fact diagnosed him of having anal cancer. So he had had anal cancer for a good 6 months, and he's fine today, 26 years later, because we got him treated. So, but early detection is even better. So these things, once they're found, early detection it's easy to fix. There's a stage at diagnosis, localized. In his case, we found it localized, and he had a 5-year survival rate of 80%. As I said, it's been 26 years later. So these are people that have cancers. If it's moved to the region, there's a 5-year survival of 60%. This is someone who actually develops cancer. So if they have distant metastasis, there's a 12% survival rate, which is what Farrah Fawcett had. She had a 5-year survival rate of 30%. I can't tell you exactly how many years after her diagnosis that she lived, but I can't say it was more than a couple of years. We use chemotherapy and radiation for treatment of these lesions if in fact they are turning into cancer. They lower your CD4 counts, you get complications. There's a psychological burden to this. There's also surgery. So the bottom line is you don't want to get anal cancer. You want to catch it before that happens, which is what we're talking about tonight. So are you still with me? All right. I like the thumbs up. So screening for anal cancer is different than screening for dysplasia. Anal cancer is often palpable, meaning you can feel it or touch it. So if someone were to put their finger, or you put your finger in your anal canal, if you had cancer, you usually can feel it because doesn't feel like it's supposed to be. It's supposed to be nice and smooth, and you'll feel some roughness. Anal dysplasia is not palpable, and you got to look at it visually with magnification and with staining. So anal cancer is anal dysplasia is way before cancer. So most patients won't admit to a problem, and trust me, most providers won't look. It's pretty amazing to me, even in medical school now, I think the training is not so much to do digital rectal examinations on patients in their annual visits, which I think is a big mistake. So if you have a problem, you have a concern, bring it up. If when you talk to your provider, they don't seem comfortable talking to you about it, find someone else. There's also the psychological impact, a negative impact after screening, being positive impact, increase over time. HPV infection and stigma. Am I contagious? I hear that all the time. We're all contagious. In some form or fashion, all of us have some form of HPV. Again, the issue is, do you have the higher risk types? Lots of patients go lost to follow-up, right? So they know they have this and they move to someplace because, again, it's not approved yet. So they move someplace where there aren't providers who are doing these procedures, and they're lost to follow-up. I've heard examples of patients getting cancer, progressing to cancer, just because they hadn't been able to follow up. So if all this is true for you, and how does this work? Well, you come in for an examination, there's preparation involved. You just kind of come as you are. You're not sedated, you're here in the office, it's an in-office procedure. There's no enemas, no douching, no prep. Like a colonoscopy, you have this horrible prep the night before. You don't, yeah, I see people shaking their heads. You've had it done, me too. And then you're up all night long, right? So you just have nothing in your anal canal for 24 hours prior. You avoid spicy foods for 24 hours. This is often told to us by patients as well. Avoid eating large meals the night before your procedure. We hear this from patients all the time. If you're on blood thinners, we ask that you hold those for a day or two if they're not medically necessary. And it's not so much for our benefit, it's for your benefit. If in fact we have to use or take biopsies of a lesion, you're going to bleed longer than normal if you're on blood thinners. So typical examples is Motrin, ibuprofen, vitamin E, fish oils, those sorts of things. Aspirin. We're going to skip this section here. So in the high resolution endoscopy, obviously we always have an informed consent. We take a history. We look at the risk factors. We examine your perianal area, your perineal area, and then the genital regions. We obtain a PAP, which is just a swab. We do a digital rectal examination with the finger. We use lidocaine and lubricant, and that helps to numb the area locally. We insert an anoscope, which is about 4 inches long. And then through that anoscope, we put in some vinegar. A vinegar solution helps us to see the lesions. We let that sit for a few minutes, and then we reinsert the anoscope and examine it with a colposcope, which is basically, a microscope. And we're able to see changes that are happening way before anybody would ever see it on a colonoscopy or just a straight visual examination. So if the doctors, providers say, well, I can see it with my eyes, then they really don't know what they're talking about, right? And when you're doing a colonoscopy, that's what they're using, is a camera in their eyes. So this is done with a microscope. Any suspicious lesions, we tend to biopsy those. People are often most concerned and worried about biopsies. My experience with most of my patients is that when they start saying to me, I'm worried about this biopsy, I say, I'm already finished, right? So most of these things, if done correctly, are not a painful process. So we use Lugol's iodine, and any areas of dysplasia often will turn mustardy brown or mahogany brown. The anal biopsy is a removal of the tissue. It's performed after an abnormal pap or visual examination. And it's the same as an HRA. A piece of tissue is removed from the anus. It's about the size of a kernel of rice. So it's tiny. And then you may have some bleeding for a few days afterwards. Any bleeding, if you ever bled in the toilet bowl, you'll notice it looks like a lot. No matter how small it is, but it's usually not a big deal, and it usually resolves in a day or two. So what patients can expect? Complications are really, really rare. You can expect some slight bleeding with bowel movements for several days. If you think about it, you have a little injury there that's been created. You can't really rest that area because you're going to have a bowel movement every day. And that bowel movement, when it comes through, it's going to kind of rip that area just a little bit. So it'd be like having a scab, and every day you pick it. It'll eventually get better. It'll eventually stop bleeding. But if you just left it alone, it would stop bleeding right away. But unfortunately, you have bowel movements every day afterwards, so you'll have some slight bleeding. So nothing inside your anal canal until there's no bleeding or you're comfortable. That's usually about a week. Infection is very, very rare. This is done as a clean procedure. It rarely requires pain meds, and rarely do you need time off of work. The one thing I tell patients is no heavy lifting after the procedure for a couple of days. Preparing for the procedure, so no aspirin 1 week before, no anal intercourse the day before, no creams or medications, sex toys, no douching, no enema. Basically nothing inside your anal canal for 24 hours. Precautions after a biopsy, we ask that you call us with any questions or strange symptoms, like if you have any bleeding that just won't stop, or you have chills or fever, abdominal pain. In the entire time I've been doing this, I've only had one patient who's really had one of these sorts of concerns. So it really is pretty straightforward. Now, if you want to take down this information, I know this will be available to you to go look up later. There's a video here that you can log into. It's a special YouTube that you have to sign in and say you're over 18. And it's an actual demonstration. I think it's almost 45 minutes long. I won't show it here tonight, but if you want to go look at it yourself, it walks you through the entire process, and you'll see that process on video. And it's done by some of my colleagues that are at UCSF in San Francisco. So why should we treat these lesions if we find them? Well, one reason is to prevent invasive cancer. That's the whole reason we do this. Sometimes with these lesions, you get itching, irritation, bleeding, pain, and some just psychosocial distress knowing you have a lesion. So we treat them to reduce those symptoms. The types of treatments, there's no specific type. There's many ways to treat these lesions. Some patients choose to treat it themselves with a topical treatment. That's available in any of the pharmacies. We can order that for you. There's a clinician-applied topical treatment. We use trichloric acid or cryotherapy, freeze therapy. Sorry. We do ablative treatment, which is probably 99% of what we do here in the office, by using what's called infrared coagulation, or we use a hyfrication electrocautery. It's laser ablation. So when we do these treatments, sometimes people are a little confused and we have to review with them. We're not ridding you of the virus. We're ridding you of the damage that the virus has caused. So as all of you know, right now we have no cures for viruses. We're all going through this COVID thing. COVID is a virus, right? And so we're probably not removing the virus itself. We're getting rid of some of it, but not all of it. So the expectation is high risk of recurrent disease after treatment. So what happens is when you go in and treat, you kind of have to stay on top of it. And I have patients that have had problems over and over and over. And if we stay on top of it regularly, usually those problems tend to go away. It's a difficult procedure for providers to learn, and they get better with time. So if you've run into somebody who's just starting this process, it's best to find someone who's actually been doing this for quite a while. There's a high risk of metachronous disease, which is like whack-a-mole. So when you take care of one, you tend to get another one that pops up in another area of the anal canal. So you need to stay on top of this. So oftentimes we have people coming in every 6 months. Again, multiple visits. There's long-term follow-up. It's almost like getting married to your provider. So there are a lot of these patients I've seen over and over and over, and they know what to expect. I know what to expect. And many of them, as we've seen them regularly, many of these areas have cleared up. And instead of seeing them every 6 months, we'll see them every year, every 2 years. 5FU is another form of treatment. I'm going to skip over that. This is the one that we use mostly, which is called Aldara imiquimod. I don't know if anyone's ever used this, but it's used to debulk areas. So if you have extensive disease, rather than treating a large area in that area, will give you a topical, will treat and also give you a topical. It's been used for genital condylomas or warts for a long time. A lot of people have had good success with that. It may cause some local irritation and pain. So Aldara is used by my dermatologist for precancers on my face. And he wanted me to use it 3 times a week for about 18 weeks. I got to about 4 weeks and I said, I can't do it anymore. So some people just can't tolerate it. And that's okay. Just talk to your provider, let them know you can't tolerate it, because there's multiple ways to treat these lesions. It's about 39% treatment efficacy, so we would follow you up to make sure things are working well. They've done some randomized trials of use of this on extensive HSIL. They found good resolution. The office-based ablation is what we do mostly. There's infrared coagulation, and then there's electrocautery or hyfurcation. There's also laser and radiofrequency ablation. The first 2 are the ones that we do here in Palm Springs. I find the electrocautery is much more effective than the IRC treatment. Treatment considerations and multiple treatment methods are often needed, sometimes simultaneously. It's not a one and done. Careful follow-up is critical. And treatment of these ACILs is improving, but more treatments are needed. The ANCHOR study is a study that's been going on for quite some time now, determining whether or not treatment of these conditions actually reduces the incidence of invasive anal cancer. The preliminary information that we're finding is it's all going well. There's still a number of years left on this study. And once they finish, if they can prove that this is the case, then we'll have consistent protocols across the nation. Yay. Let's see. Here's hyfurcation. It's faster, more precise. In my experience, it's actually better and destroys the lesions better. That tends to be what I use. However, it generates a smoke plume, so we're all wearing masks, not just for COVID, but we wear masks in there, so we're not inhaling the HPV that might be in a smoke plume. So the ANCHOR study, okay, my finger's not working real well. We're basically looking at outcomes, Primary goal is, does treatment affect the natural history of this? And should we screen for anal cancer? Is it something we should be doing? Does it make sense? Is it logical? The protocol of this is Dr. Joel Palevsky. We work really closely. Co-chair is Michael Berry. We work really closely with these two individuals. They're out of UCSF. Sponsored by the National Cancer Institute. Open sites that have been approved. Anyone who's interested in Anchor. The Desert AIDS Project is currently a site. They're targeting over 5,000 participants. The population is men and women over age 35 who have HIV infection and biopsy-proven high-grade lesions with no history of anal cancer. Treatment or removal of these high-grade lesions within 6 months. Eligibility, who qualifies for the study? HIV positive men and women. You got to be 35 years or older. No known history of anal, penile, vulvar, vaginal, cervical cancers. No known treatment or removal of high-grade lesions in less than 6 months. And the participant has to have high-grade lesion proven by biopsy. It's a pretty cool study. You're followed really closely. There's 2 different angles to it. One is one arm that you get randomized to is treatment. The other is observation. So some people think, well, how do you know that they have a high-grade lesion and they're observed? How could you let that happen? The incidence of the number of times that you're seen and followed up if you had the lesion without treatment, if you develop cancer, you've caught it immediately. So it's much faster than if you had never been involved at all. And so we're having good uptake on the study. People can't be on chronic steroids or immunomodulatory agents, and they can't have any symptoms related to their HCell and no extensive warts. So you don't have to be great to get, can I move this? Yeah, to get started, but you have to get started to be great. So if you've not been involved with this before and you're interested in it, we offer here at Eisenhower, and I think they also do at DAP, a consultation. It's a quick 30-minute appointment. If you don't really understand this and you want to hear more about it, you can hear what your various options are. Just get started. Here's some references. Where are we with time?
We have about 15 minutes in total.
Cool.
So we'll take some Q&A at some point.
So we're almost there, you guys. We're almost there. I thought that was cute. That's it that I have for my presentation. My biggest fear, though, being a bat hanging upside down, do you know what I fear most about old age? One says, no, what? He says incontinence. So with that, I'll take any questions that we might have.
Well, John, I just wanted to let you know I've been laughing at all of the jokes.
Oh,
You just couldn't
good.
hear me. You just couldn't hear me. And I
Did
love
you?
the bunny. I love the bunny one a lot.
The bunny was cute, huh? I like the bats hanging upside down.
Yeah, that is kind of gross, isn't it? Because
You don't want to have incontinence while you're
No.
hanging it upside down.
No.
Yeah. Brett, you said something?
No, I was just going to say that people, if you have a question on the call, please feel free to unmute yourself. You can do that on your end or raise your hand or give us a signal and we'll help you there. Ask a question. One question I do have is, so when you're seeing your regular physician and you do your annual exam and they do a anal test or whatever, and then they send it out and they get the results back, once you've come to that you're predisposed to HPV, I guess it is, or that we need to come see you specifically, do we need to have that test done again annually with our regular physician, or do we now just see you as our primary in this regard?
So it's a great question. There's a couple of things. I'm going to answer part of it that you didn't even ask. And part of that is what I find often with providers, and it's not here, but it's all across the nation, is oftentimes when they're looking at your overall health in your annual visit, no one ever talks to you about sex. So if that's not happening, then it should happen, right? Because if you're having anal receptive sex, or if you have cervical dysplasia, those sorts of things, there's so many women here who have abnormal pap smears because of HPV who are not getting an anal pap. And because of these two areas anatomically are so close, oftentimes there will be an HPV infection there. Hence, that's how Farrah Fawcett more than likely got it. So that being said, make sure your provider is talking to you about sex. And if they're doing the screen, great question. When you finally get referred and you're in to see us, if we're going to see you on a regular basis, we'll do your annual pap for you when you come in for that examination. Did that answer your question?
It did. Thank you.
Sure. What else?
Well, if you didn't see it in the chat, if you want to go to the chat, Guillermo has put in the link to that YouTube video.
Thank you.
Those on the call.
So the Desert AIDS Project has an anoscopist right now. They also are, I think they're hiring an individual who has a lot of experience. They're bringing them in, I think, from LA. I don't think they're hired yet. So there's a new person coming in over there. We're currently training a women's healthcare professional here that currently does women's health here at Eisenhower. And she'll also be doing HRAs. She'll be training under Dr. Gehring and I in the colorectal area. Of course, I'm doing them here as well. We're moving our practice from full-time being here at Rimrock to, it'll be eventually full-time on the main campus at Eisenhower in the colorectal surgical center. That's a big step up to create a dysplasia clinic in and of itself, which is exciting for me. And I think Borrego was doing them. I'm not sure if there's any provider there that's currently doing them now. So in the area, we're nicely covered. San Francisco does this a lot, San Diego, Los Angeles. So in Southern California, we're pretty well covered for these type of procedures.
Blaine, did you have a question? I saw you came in.
Kind of. So Dr. Adams left Rimrock and he did my HRAs.
Yeah.
When it comes time in May or June of next year, can I call back to Rimrock, or will you be over at the main campus?
You can call either area. If you want to call the Salta Center over there, by that time we'll be at the main campus full time. But if you forget and you call here, they'll know.
Yeah.
And because they'll have our schedule, because we know the patients are transitioning.
Gotcha. Yeah, because I don't know if I'm enrolled in the anchor study or not.
At DAP?
No, it would be at Eisenhower.
Yeah, so the Eisenhower does not have the anchor study.
Oh, okay.
Yeah, so if it's here, it would not be.
Gotcha.
If you want it to be, though, in the anchor study, you could always go to DAP. You don't have to be a DAP client to be in the anchor study.
And then you could still get your testing and stuff done here as well.
Oh, okay. Gotcha.
Yeah.
It's not they're not mutually exclusive.
Right.
We work in partnership on many things, so that would be a easy kind of component.
Good question.
Yes, because I have been through the surgical thing twice already.
Yeah.
And I really don't want to go back there again.
Right. Exactly. I hear you.
So in this case, what is the protocol then if they're working together? Do we go to DAP? Do we go through our primary care physician in Eisenhower? What is the right protocol?
Well, are you currently under the care high resolution endoscopy? Have you done one before?
No, I
Oh.
was supposed to get it done with James Adams and he left.
Okay. So you can always come in for a consultation here with me at Eisenhower. I assume you're still an Eisenhower client?
Yes?
Yeah. So just call in to our office here at Rimrock and make an appointment for a consultation, and we'll talk you through it, and we'll do that testing as well.
Okay.
Good question.
And that is the big first question. So if you've never had one done, there are no symptoms of any kind that you would even know about.
Yeah.
And you're seeing say your annual exam, if you decide to do one with your physician, male or female, you should be asking the question of them at a certain age, should I get a HRA test? Should I, what is that? What should you be asking your physician, I guess is the big question.
So you're fit currently right now, as I said, thanks for that question, Brett. We're developing a full-on dysplasia clinic here through the GI, the colorectal area, I should say, on the main campus. So we're in the process of transitioning over there full-time. That being said, as I mentioned, this is all not approved. There's no CDC guidelines. So we're writing our own guidelines right now based on what we're seeing and what we know to be the case, and in collaboration with UCSF, who's running the anchor study. And so that being said, we'll be sending out guidelines to primary care providers about who to screen, how to do it, so on and so forth. But in the meantime, if you have had anal receptive sex, if you have any of those conditions that we mentioned, cervical dysplasia, those sorts of things, you should be screened. And if your primary care provider is not familiar with it, then you can always, in terms of here, come here for a consultation and we'll take care of that for you until we get all the primary care providers trained on what it is they need to be looking for. And it's going to be a big hurdle just to get people to consistently talk about sex, right? Because that's usually the last thing that they want to chat about. They're great at blood pressures and they're great at diabetes and they're great at, those sorts of conditions. And oftentimes sex gets put on the back burner.
All right, any other questions from any participant on the call? Not.
You guys, this is my first time doing this on a computer like this, and thanks for making it easy.
Yep. Did a good job. Good job,
Thank
Jon.
you.
And thank you so much. And the no questions, I think, kind of means that you are so thorough.
Is that it? Yeah.
Yes, that's it.
Or just people are just overwhelmed.
So thorough that they got it. They got all the
We're getting
information that they needed.
We're getting a thumbs up. Thank you.
Yes. Thank you much for coming up tonight and doing this for us. And like I said, you did a good job and you're first. And so we baptized you, and I think you'll be ready to do more of these as we move forward.
Oh, good, good.
Yeah.
Thank you.
Yep. Yay, done.
Yay. Thank you. Yay to you guys as well.
All right. Thank you, everybody.
Have a good
Thanks.
night.